Alright guys, we're going to pick up with wrong slide. Techniques of artificial ventilation. In this section we're going to be discussing the differences between normal spontaneous ventilation and positive pressure ventilation, because there's some various physiological differences between someone breathing on their own and us breathing for them. Some differences that you'll see with a patient that is breathing on their own versus positive pressure ventilation, for starters, will be the air movement. Because in a normal ventilation, a person creates that negative positive pressure change. During negative pressure, they're increasing that size of the thorax that draws air into the lungs. During positive pressure ventilation, it is simply just that. You are delivering ventilation through positive pressure. There is no positive negative pressure change. So you're forcing air into the lungs regardless of the pressure changes within the thorax. With the application of positive pressure ventilation, the patient does not have to rely on his or her own ability to produce negative pressure. You're also going to see some differences with airway wall pressure. This normally is not affected during normal ventilation. However, during positive pressure ventilation, the airway walls are pushed outward, creating a larger space. This requires larger volumes to fill the larger space and ventilate the patient effectively. The esophagus, now remember this is a soft, flexible structure. During normal ventilation, the esophagus remains closed, so that way no air moves into it. However, when we're providing positive pressure ventilation, this can overcome the patient's esophageal opening pressure, thus allowing air to enter into the esophagus and fill the stomach with air during ventilation. This ultimately could lead to gastric distension and the possibility of regurgitation. A patient's cardiac output is also affected between normal spontaneous ventilation and positive pressure ventilation. During normal spontaneous ventilation, this does not affect the cardiac output or the blood pressure of the patient, because the negative pressure that's generated within the thorax prior to inhalation acts like a vacuum and sucks venous blood into the inferior vena cava from the body below the level of the diaphragm. This provides an adequate amount of venous blood volume to the right side of the heart. Preload is dependent on the venous volume and amount of blood ejected from the right ventricle. An adequate preload contributes to an adequate stroke volume, cardiac output, and blood pressure. During positive pressure ventilation, the thorax becomes positive during the inhalation phase as air is forced into the lungs. With the loss of the negative pressure generated during normal ventilation, the vacuum effect is diminished and the venous return decreases. This then decreases the preload, which reduces the stroke volume, cardiac output, blood pressure, and perfusion of your patient. Some considerations that you want to take when considering artificial ventilation: whether it is provided by a mouth mask, bag valve mask operated by a single person or two people, using a flow restricted device, or you want to make sure that you're able to maintain a good seal. So that way there's no leakage and you're ensuring that you're getting air into the lungs. You want to make sure that the device that you're using is able to give the volume of air needed to inflate the lungs. So with your BVMs, we have an infant, a child-sized, and an adult size. So you want to make sure you're using the right size bag for the patient. And you also want to make sure that there's a way for you to connect oxygen to your device while ventilating your patient. As with any technique in which there is a risk of coming into contact with body fluids, it is necessary to take standard precautions when performing artificial ventilation. The risk of coming into contact with secretions, blood, or vomit while ventilating are relatively high. Therefore, at minimum, you should make sure that you have gloves and eyewear on. If large amounts of blood or secretions are present, you should also consider wearing a face mask. And if tuberculosis is suspected, you should also wear an N95 or HEPA mask, HEPA mask, respirator during the entire patient contact. Some indications that would show that you're ventilating your patient adequately: you're delivering your breaths at a sufficient rate, so each breath should be given over 1 second. For newborns, that you should be ventilating 40 to 60 times per minute. So basically a breath every 1 to 2 seconds. In infants and children, you should be breathing every 12 to 20 breaths times per minute, or every 3 to 5 seconds. In adults, you should be ventilating 10 to 12 times per minute, or once every 5 seconds, pending they have a pulse. If no pulse, ventilations are performed in conjunction with chest compressions at a rate of 30 compressions to 2 ventilations, unless an advanced airway is in place. In a newborn without a pulse, the ratio of chest compressions to ventilations is 3 to 1, or 90 compressions to 30 ventilations. The tidal volume should also be consistent. It must also be sufficient to cause the chest to rise during each ventilation. Inspect the chest with each ventilation to ensure adequate chest rise and fall. Some other indications: the patient's heart rate should begin returning to normal. As well, if they are cyanotic or palish in color, their color should be beginning to improve as well. Signs of inadequate ventilation, whether it should be, for example, the ventilation rate being too fast or too slow. Ventilating a patient too fast does not allow for adequate exhalation and thus can cause gastric distension. Too slow a rate of ventilation also does not provide an adequate amount of oxygen. Another sign would be the chest not rising and fall, because that means you're not getting enough volume to ensure an adequate delivery of air to the patient. This could be due to a failure to use the ventilation device properly, or there is some type of airway obstruction. If the heart rate does not return to normal when providing artificial ventilation, that would be another sign that you're not ventilating properly. However, take into consideration other sources of heart rate disturbance, such as blood loss, anxiety, or potential heart problems. Also, if they have that pale or cyanotic color to them, if it does not improve, that also means that you're not ventilating your patient properly. Cricoid pressure was once thought to reduce complications associated with positive pressure ventilation when the unresponsive patient's airway is not protected by an advanced airway device. In this situation, the technique was intended to reduce the incidence of gastric inflation and aspiration of gastric contents. However, it has been found that cricoid pressure may actually impede airflow during ventilation. Thus, gastric inflation is best controlled by maintaining slow ventilation at a reduced volume. Now, if you are having to perform cricoid pressure because the medic may need it to assist in intubation, you want to locate the thyroid cartilage, which is your Adam's apple, by sliding the index and middle fingers slowly down the chin until you feel an obvious cartilage prominence. You want to continue downward until you feel the base of the thyroid cartilage, and below it a small, soft midline indentation. Below that membrane is the bulky cricoid cartilage. You then want to place your index finger on one side of the cricoid cartilage, your thumb on the other side, and apply firm backward pressure. You want to make sure that you avoid completely compressing the cartilage. Now, if burp, which stands for backward, upward, rightward pressure, you're going to use the similar landmarks as you would with cricoid pressure. You're going to locate the cricoid, locate the thyroid, then you will then apply backward pressure towards the spinal column and push the cartilage up and towards the chin, and then lateral to the patient's right. You will then hold this maneuver until the person performing the laryngoscopy instructs you to release it. Now, ELM, or external laryngeal manipulation, is a technique similar to burp. As with burp, you apply pressure to the thyroid cartilage. However, with ELM, the paramedic who is performing the laryngoscopy guides the EMT's hand to provide the best glottic view. So in this case, you will locate the thyroid, place your thumb on the left side and your fingers on the right side of the thyroid cartilage, and then the medic that is performing intubation will then place his or her right hand on top of yours and apply pressure and manipulate the larynx until the glottic opening is brought into view. And then you will hold this position until the medic instructs you to release it. Some other considerations when using one of these three methods: the cricoid cartilage is the only complete cartilaginous ring. When forced backwards, it may collapse the esophagus behind it against the cervical vertebrae, preventing air from traveling down to inflate the stomach and stomach contents from moving up. If the patient begins to regurgitate, release the cricoid, burp, or ELM pressure to prevent an esophageal tear. Immediately turn the patient then onto their side, if possible, and suction the airway until clear. Proper positioning of the airway with the head tilt chin lift maneuver will also help to prevent gastric inflation. So, let me get my pointer here. So here's your thyroid. There's that thyroid cartilage. Just below it is the cricothyroid membrane. So when you're doing this, if you're doing the cricoid, you'll just push directly back and then burp or ELM as appropriate. But this is your landmark. That's what you're looking for. With mouth-to-mouth ventilation, this technique provides adequate volumes of air for ventilating a patient. Now, it does have some major limitations, such as the inability to deliver high concentrations of oxygen while ventilating, plus the risk posed to the EMT by contact with the patient's body fluids. To reduce this risk, a barrier device should be used. If using mouth-to-nose ventilations when the patient's mouth cannot be open, such as when severe soft tissue or bone injury has occurred to the mouth or around it, in infants, or when you cannot achieve a tight mouth-to-mouth seal, is when you use the mouth-to-nose ventilation. With mouth-to-mouth or mouth-to-nose, you are still able to deliver enough oxygen for the patient to use. Because when you breathe in air, such as the air that we are breathing in right now, we are breathing in 21% oxygen. Our bodies only use about 5% of it. So when we provide oxygen by mouth-to-mouth or mouth-to-nose, you are still giving the patient 16% oxygen, so enough for them to be able to oxygenate appropriately. With mouth-to-mask or bag valve mask in ventilation, there are some considerations you want to take. If the patient does have a pulse, the amount of air volume delivered to the patient should be approximately 10 milliliters per kilogram, or enough to make the chest rise adequately and effectively with each ventilation. Each ventilation should be delivered over a 1-second period. And if the patient has an advanced airway in place, the ventilation rate in the patient without a pulse is reduced to 10 ventilations per minute, or 1 breath every 6 seconds. Once the EMT provides continuous chest compressions at a rate of at least 100 compressions but no greater than 120 compressions per minute without pausing for any ventilation. It is also important not to overventilate the patient by providing either too fast a rate or too great a volume, because this could then lead to gastric inflation or damage to the lungs. Decreasing the ventilation volume is aimed at reducing the incidence of gastric distension and the potential regurgitation and aspiration that could occur during mouth-to-mask or bag valve mask ventilation. A smaller tidal volume reduces airway pressure and avoids causing the lower sphincter in the esophagus to open. When the stomach begins to become overinflated with air, several complications may occur. The air-filled stomach may cause stomach contents to enter the esophagus, thus leading to regurgitation and possible aspiration. Aspiration of gastric contents may interfere with gas exchange and cause pneumonia. Also, an inflated stomach places pressure on the diaphragm, which could then elevate the diaphragm and restrict its movement. When supplemental oxygen is connected, adequate oxygen saturation can be maintained with smaller tidal volumes. Mouth-to-mask ventilation is the preferred method to use when performing artificial ventilation because of the following advantages. One EMT can ventilate using the two-handed mask seal technique, thus achieving a better mask seal. The mask also eliminates direct contact with the patient's nose, mouth, and any secretions that may be coming out. Use of a one-way valve at the ventilation port prevents exposure to the patient's exhaled air. The method can provide adequate tidal volumes and possibly greater tidal volumes than bag valve mask ventilation. Supplemental oxygen can be administered to the oxygen inlet that most pocket masks have, in addition to the ventilation port. However, where anything has advantages, they also do have disadvantages, such as the mask does make a perception by some EMTs as having an increased risk of infection. The EMT providing the ventilation may also fatigue after a period of time, especially if they're having to do CPR at the same time. The device, however, also does not allow for the highest possible concentration of oxygen to be delivered with each ventilation. The mask used to ventilate the patient should also have these characteristics. It should be made of a transparent material to permit the detection of vomit, secretion, blood, or any other substance that may be in the patient's mouth. It should also be able to fit tightly on the patient's face and form a good seal. It should also have an inlet to allow for high concentration oxygen delivery up to 15 liters per minute, and it should be available in one average adult size and additional sizes for infants and children. When performing mouth-to-mask ventilations with no suspected spinal injury, you'll place the mask just like you normally would, set your oxygen to flow to 15 liters. Preferably, if possible, you should position yourself at the top of the patient's head. This is referred to as a cephalic technique. This allows you an easier way for you to monitor the patient's chest rise and fall in this position. However, if you are performing one-person CPR, it is better to position yourself at one side of the patient's head. This is called the lateral technique. It is the preferred technique when performing one-person CPR because it allows easier movement from the chest to the airway to provide both chest compressions and ventilations. Place the mask on the patient's face, and the narrow top portion of the mask should be seated on the bridge of the nose, and the broader portion should be seated in the cleft above the chin. You will then hold the mask with the CE technique, placing your thumbs on the top and lateral edges of the mask. Thumb sides of your palms along the sides of the mask, and your index fingers up over the bottom of the mask over the cleft above the chin. In this way, your thumbs and index fingers form C's around the mask chimney. You will then pull upward with your middle ring and little fingers grasping under the mandible in the form of an E just in front of the earlobes. You will then pull forward on these fingers to lift the mandible upward and lift the chin. While lifting the mandible upward, tilt the head back, performing a head tilt while achieving a chin lift by lifting the mandible to the mask. You will then place your mouth around the one-way valve and blow into the ventilation port of the mask. Give a breath over 1 second period. When the chest rises adequately, stop the ventilation to allow for exhalation. If you cannot ventilate or if the chest does not rise adequately, reposition the patient's head and try again. Improper head position is the most common cause of difficulty with any ventilation. If the second try also fails, assume the airway is blocked by some foreign object and follow the guidelines for removing a foreign body airway obstruction. Now, if you suspect a patient has a spinal injury, you must establish and maintain spine motion restriction. You will then ventilate the patient with the mouth-to-mask technique, taking care not to manipulate the head and neck during the procedure. You will position yourself, if possible, at the top of the patient's head. Place the mask on the patient's face. Hold the mask with the CE technique. Pull upward on the angle of the jaw to lift the mandible upward and to lift the chin forward without tilting the head backward and keeping the head and neck in a neutral position. Make sure you squeeze the mask tightly to achieve an airtight seal between the mask and the patient's face, and then deliver ventilations as you would in a non-spine injured patient. If the ventilations are ineffective and are not producing adequate chest rise and fall, it is necessary to immediately identify and correct the problem. Always start with the easy one. Check, make sure that the head and neck is in the correct position, so you may need to reposition it. If you have a patient with a suspected spine injury, reposition the jaw thrust while keeping the head in a neutral position. Readjust your mask and make sure that there are no seal leaks between the face and the mask. Attempt administering a greater tidal volume, and if that still does not work, consider inserting an oropharyngeal or nasopharyngeal airway to assist in maintaining an open airway. With bag valve mask ventilations, one advantage of this device over the mouth-to-mask ventilation is its convenience for the EMT and its ability to deliver enriched oxygen mixtures. Also, if 2 EMTs are performing the procedure, one EMT achieves and maintains the mask seal with 2 hands, while the second EMT squeezes the bag to deliver the ventilation. The BVM device is harder to use than it looks, and the operator can become fatigued from performing a one-person technique. Some other advantages of it is it does allow us to monitor their CO2, as well as administer medications when appropriate. When using this, make sure that you are using the correct size bag, whether it is for an adult, child, or infant, where it's administering enough volume to cause the chest to rise. A bag mask device should have the following features. It should have a self-refilling bag that is disposable or easy to clean and sterilize. It should have a non-jamming valve system that allows a maximum oxygen inlet flow of 30 liters per minute. That'll be back here. Either a pop-off valve or a no pop-off valve that can be manually disabled. This valve is disabled. If not disabled, may lead to inadequate ventilation. Standard couplings for masks, endotracheal tubes, tracheostomy tubes, LMAs, and combi tubes. An oxygen inlet and a reservoir that can be connected with an oxygen source to deliver high concentrations of oxygen during ventilation. An oxygen reservoir should be used when ventilating all patients. It should also be adaptable to all environmental conditions and temperature extremes, and should also have a transparent mask to permit detection of vomit or any secretions during ventilations. Oropharyngeal or nasopharyngeal adjuncts can also help in maintaining an open airway and should be used anytime the BVM device is used. When applying the mask, it should fit securely over the bridge of the nose and in the cleft above the chin. In a patient with no suspected spinal injury, the first thing you're going to do is open the airway using the head tilt chin lift. Raise the patient's head slightly with a towel or pillow to achieve a sniffing position. Make sure you have the correct size of mask. You will then place the mask over the patient. Position your thumbs over the top half of the mask and your index finger over the bottom portion of the mask. Use your ring and little fingers to bring the patient's jaw up to the mask using that EC technique. Have another EMT connect the bag valve to the mask if it is not already attached. Begin ventilations as soon as possible. The other EMT or qualified person will squeeze the bag with 2 hands and deliver the ventilation steadily over 1 second while watching for adequate chest rise. Make sure that you're delivering your breaths accordingly depending on the age of patient you have. When you must operate the bag valve mask alone, apply the mask to the patient's face with 1 hand. Your thumb should be placed over the part of the mask covering the bridge of the nose and your index finger over the part covering the cleft above the chin. Seal the mask firmly on the face by pushing down with the thumb and index finger while pulling up on the mandible with the other fingers to maintain a head tilt chin lift. Squeeze the bag with your other hand while observing chest rise to make certain the lungs are being inflated effectively. If you are ventilating with a bag valve mask and the patient's chest does not rise or fall, reevaluate your BVM device and the patient's airway. In a patient that you suspect to have a spinal injury, you must establish and maintain spine motion restriction. The airway maneuvers and use of the bag valve mask technique must be performed with special care to avoid movement of the head or spine while maintaining spine motion restriction. You'll open the airway using a jaw thrust maneuver, and with another EMT or trained assistant maintaining spine motion restriction while you select the correct size mask. If no other personnel are available, you can kneel at the patient's head and hold their head between your thighs and knees to prevent movement. Position the mask over the patient. Use your hand to form that EC hand position, and without tilting the head back or moving the neck, lift the jaw into the mask. Connect the bag valve device if not already done, and squeeze the bag with the other hand. The FRO-PVD, or Flow Restricted Oxygen Powered Ventilation Device, is an aid in ventilating a patient in cardiac arrest when used in the manual mode, which requires the EMT to trigger the device to deliver a ventilation. Avoid the automatic mode in cardiac arrest because it may cause an increase in positive end pressure and expiratory pressure, which means air is remaining in the terminal bronchioles and alveoli, which may lead to a decrease in blood return. The FRO-PVD is only meant to be used with adult patients. Make sure the unit is functioning properly before its use, and also ensure oxygen is connected to ensure there is an adequate supply to operate the unit effectively. Open the airway using the head tilt chin lift if no spinal injury is suspected. Connect the device to the mask, and an adult with a pulse should be ventilated once every 5 to 6 seconds, unless they are in cardiac arrest, which they will be ventilated twice after every 30 compressions. When using the flow-restricted oxygen-powered ventilation device, you'll hit the button at the top of the mask to release a breath of air. Once the chest begins to rise, deactivate the valve by releasing the trigger or button. Automatic transport ventilators. This is what we use for patients that are intubated on prolonged transports. Some advantages of this: it frees the EMT's hands to hold the mask and maintain the airway position as the device delivers ventilations automatically. This can also be set to provide a specific tidal volume or respiratory rate. It also has alarms that indicate low pressure in the oxygen tank and accidental disconnection of the ventilator. However, because the ATV is usually oxygen powered, once the oxygen supply is depleted, the device cannot be used. A pocket mask or bag valve mask device must always be available when using an ATV in case of failure or of oxygen depletion. You want to make sure that you are aware of the capabilities of your equipment, because some ATVs cannot be used in children less than 5. And when using the ATV device, it is not possible to feel an increase in airway resistance or a decrease in the compliance within the lungs. The unit should also have an adjustable inspiratory flow of 30 liters per minute for the adult and 15 liters per minute for the child. A rate of 10 breaths per minute for adults and 20 breaths per minute for children, and an audible alarm that indicates peak inspiratory pressure is generated and alerts the EMT that the lung compliance is low or the airway pressure is high, which thus results in a lowered delivered tidal volume. Some ATVs have a demand valve built in, so that way if the patient begins to breathe spontaneously. The automatic transport ventilator is excellent at providing and maintaining a constant rate and tidal volume during ventilation, and also maintaining adequate oxygenation of arterial blood. In addition, most ATVs use oxygen as their power source, thereby delivering 100% oxygen during ventilation. Continuously monitor both the device for proper functioning and the rise of the patient's chest for adequate ventilation. If a failure of the device is detected or suspected, immediately discontinue use of the ATV and begin ventilation with either a pocket mask or a bag valve mask device. Make sure that you're able to recognize the need to ventilate a patient who is breathing but breathing inadequately. Complications include uncooperative patients, inadequate mask seal, and overinflation of the lungs. Patients that are breathing who would need ventilation are those that have a reduced minute volume due to either an inadequate respiratory rate or an inadequate tidal volume. CPAP, or continuous positive airway pressure, is a form of non-invasive positive pressure ventilation. We use this in patients who are awake and are breathing on their own who need ventilatory support, such as a patient who has congestive heart failure and has fluid within the lungs, or an asthma patient who has severe bronchoconstriction and it forces air into the lungs, forces those bronchioles open, and if there's fluid, it forces that fluid out of the lungs. CPAP is often used to avoid the need to place an endotracheal tube or other advanced airway to artificially ventilate your patient. A common goal of CPAP is to reduce a patient's work of breathing and buy time for more definitive treatments to work. As I already noted, CPAP is delivered via a tightly fitted mask and a device that generates a continuous flow of air through the airways under positive pressure that is higher than normal air pressure. The continuous delivery of air under positive pressure, which is measured in centimeters of H2O, is intended to inflate collapsed alveoli, improve oxygenation, improve pulmonary compliance, and reduce the patient's work of breathing. Left ventricular failure increases hydrostatic pressure inside the pulmonary capillaries, thus forcing fluid out of the capillaries and into the adjoining alveoli, displacing the air in the alveoli and inhibiting gas exchange. The continuous pressure created in the alveoli by CPAP prevents further fluid leakage into the alveoli and forces fluid that may already have accumulated out of the alveoli and back into the interstitial space in the capillaries. CPAP improves the heart rate and blood pressure and reduces the sympathetic tone by improving gas exchange and oxygenation. CPAP is delivered at a continuous airway pressure from 4 centimeters of H2O to 20 centimeters of H2O. Most often, CPAP is initiated at the lowest setting and titrated up to an optimal setting for the patient. CPAP may be an effective therapy if a child is able to tolerate the treatment and the patient interface or mask fits appropriately. So make sure check your protocols because many protocols restrict CPAP to only patients over the age of 12. For patients to be able to use CPAP, they should be awake and fully alert enough to obey commands and be able to maintain their own airway. They should also be able to breathe on their own and have a respiratory rate of greater than 25. They should be hemodynamically stable and exhibiting signs and symptoms of moderate to severe respiratory distress or early respiratory failure, such as use of accessory muscles or an SpO2 of less than 94%. They should also be able to wear the face mask or interface chosen comfortably. The indications for CPAP for the patient in moderate to severe respiratory distress or early respiratory failure, but who is alert and awake enough to obey commands, maintain his own airway and continue to breathe on his own. They may have symptoms such as congestive heart failure, COPD, pneumonia, asthma, or pulmonary edema. However, CPAP is contraindicated in patients who are apneic or in respiratory arrest, a GCS less than 11, unable to maintain their own airway, or they are unresponsive. If a patient is in shock or in cardiac arrest, we do not use CPAP, and if they are vomiting or have an upper GI bleed or history of recent gastric surgery. Also, any patient with a pneumothorax or trauma to the chest, especially one with penetrating trauma, do not get CPAP. Any patients with a tracheostomy or a condition where increased intrathoracic pressure causing hypotension would be indicative of not getting CPAP. When preparing to administer CPAP, you want to make sure that the patient is aware of what's going on and coach them with what's going on. Because a lot of times when you place patient on CPAP, they're going to initially feel like they are suffocating or being choked. Ensure that you have an adequate oxygen source because most CPAP devices use oxygen as their source of pressure. And have the patient in a seated or semi-Fowler's position. Assemble the device, place the mask over the patient's nose and mouth, and once you have it positioned, secure it tightly with the straps to limit airflow loss. Slowly increase the CPAP pressure by increments of 2 centimeters until the patient's response improves. Once administered and working effectively, continue to coach the patient through the process. Once you apply the CPAP, we cannot take it off until we get to the hospital, or if you run out of oxygen or the patient stops breathing. You also want to make sure that you are assessing the patient's response to CPAP, whether by watching the respiratory rate, because you should see a decrease in their rate. Their heart rate should begin to improve as their oxygenation levels improve. You should also monitor their systolic blood pressure, because as you have an increase in intrathoracic pressure, it can cause a decrease in venous return, thus leading to a reduction in preload. As preload decreases, the systolic blood pressure will also decline. If hypotension or signs of poor perfusion become evident, it may be necessary to reduce CPAP pressure or support. If the patient already has a low systolic blood pressure, it may be necessary to consult with medical direction prior to initiating CPAP. Also, if any of these conditions occur, such as gastric distension, pneumothorax, or decreased mental status, it would be necessary to discontinue CPAP and select an alternative treatment. BiPAP, or bilevel positive airway pressure, is like CPAP. With BiPAP, one level of pressure is delivered when the patient inhales, also known as inspiratory positive airway pressure, and one level of pressure is delivered when a patient exhales, known as expiratory positive airway pressure. When a spontaneously breathing patient is overventilated, where the rate and volume delivered with the ventilation exceeds the recommended rate and volume, large amounts of air may become trapped in the alveoli, thus causing pressure in the chest to remain higher than it should during inhalation and exhalation. The overinflated alveoli may cause the capillaries in the lungs to become compressed and obstruct blood flow to the left atrium. Also, the constant high pressure in the chest would reduce the negative pressure that can be generated, thereby reducing the vacuum effect that sucks blood into the right side of the heart with each breath. This would then cause a reduction in the blood volume that is available to the left ventricle, causing a reduction in cardiac output. Alright guys, we're going to take a break here. Y'all stretch your legs, use the restroom, whatever you need to do, and we will be back shortly.